Everyone, welcome to the Network Physiology webinar series. My name is Ali Mani, and I'm one of the organizers of a series of webinars on the emerging field of network physiology. This is our third session of the series, which is dedicated to network physiology applied in respiratory disease and in critical care. This session will feature two talks, with each talk lasting approximately 25 minutes. After the second talk, we will have a question and answer session. I would like to thank the speakers who accepted our invitation, and also the Physiological Society for making this event possible. My colleague, Dr. Tope Oyalade, is the other organizer of the session, and I would like to ask Tope to say a few words.
Thank you very much, Ali Reza, for that introduction. Once again, welcome everyone to today's session. Before we start, I would like to just go through some few housekeeping instructions. Please be aware that this webinar is being recorded for the purpose of publishing it for future reference. So we will kindly ask you all to keep your microphones and video cameras off for the duration of the meeting. Again, today's meeting we go over some aspect which the speakers will go in details on. When we get to the question and answer, please submit any questions through the chat. So this can be submitted anytime during the talk. Questions can be typed at any time during presentation. All questions will then be directed to the speakers and chairs during the Q&A session, which will come, like Ali Reza said, at the end of the talks. Without much ado, I think I would like to introduce today's first speaker. So today's first speaker is Dr. Amar. It's my pleasure to introduce Dr. Amar Shah. Amar is a respiratory consultant at the Royal Free Hospital, London, with a subspecialty interest in sleep and ventilation. He studied medicine at Imperial College, London, and joined UCL in 2019 to conduct his PhD. Looking at the role of wearable technology in chronic respiratory disease. During this time, he developed a keen interest in network physiology by learning from and later collaborating with Dr. Mani, one of the co-organizers, and the Network Physiology Lab at the UCL. His current research focuses in looking at the value of network physiology mapping in diagnosing and risk stratifying sleep apnea. We're delighted to have Amar with us today to discuss the role and application of physiological network mapping in sleep disordered breathing. Please take the floor, Dr. Amar Shah.
Thank you very much, Topi. I'm just going to share my screen and we can get going. So thank you very much to both the organizers and the Physiological Society for letting me speak. Hopefully you can see my slides and can hear me. So I really want to talk about physiological network mapping in sleep disordered breathing. I've got no conflict of interests to declare. And as a brief outline, wanted to first introduce the concept of sleep disordered breathing, as I appreciate not everyone will be aware what sleep disordered breathing means, and why network physiology has a role in sleep disordered breathing, and then some of the data from our pilot work that we've conducted thus far. So sleep disordered breathing really describes a group of disorders characterized by an abnormal breathing pattern during sleep. And there are two of the most common disorders, either obstructive sleep apnea or OSA, and obesity hypoventilation syndrome. And I just want to take a little bit of time to talk a little bit about each of these in turn, to try and explain them a little bit more. So obstructive sleep apnea, really sleep apnea occurs when breathing stops and starts while you sleep. And so on the left of your screens, you've got a normal breathing pattern with an airway that's open. However, in obstructive sleep apnea, the airway becomes blocked, so the walls of the throat relax, they narrow and they collapse during sleep. And this is an intermittent phenomenon that occurs subconsciously or consciously, waking the patient up. The airway then opens up again, and patients are getting intermittent periods where they're dropping their oxygen saturations, temporarily stop breathing, and this is obviously causing fragmented sleep and has downstream consequences, which I'll talk about in a little bit. How do we diagnose obstructive sleep apnea? So we diagnose obstructive sleep apnea with a sleep study, and there are varying different types of sleep studies. And I know those who have attended the first webinar and the second webinar, a lot of our data really comes from full sleep studies, what we call polysomnographies, which have sort of EEG channels, as well as nasal cannulae, abdominal thoracic belts, heart rate, saturation monitoring. However, this is quite labor intensive from a point of view of clinical practice. And so we often use what we call a limited channel polysomnography, which still has a fair number of channels. So it will still have nasal prongs, an abdomen and thorax belt, and oxygen saturation, and heart rate monitoring. I should say that obstructive sleep apnea is extremely common. So there's about 1 billion people worldwide that suffer from the condition. A lot of it remains undiagnosed, and it's likely to increase in its prevalence due to the rising obesity pandemic, really, that we're seeing worldwide. Just to look at that a little bit more detail, so what are we actually looking at? So the top picture really looks at nasal flow. And so really we diagnose obstructive sleep apnea based on nasal flow and nasal flow reduction. So an apnea is defined as a 90% reduction in nasal flow that lasts at least 10 seconds, and it may or may not be followed by a desaturation. A hypopnea is defined as a 30% reduction in nasal flow that lasts for 10 seconds, but it has to be followed by at least a 3 or 4% desaturation. And overall, the severity of obstructive sleep apnea is really defined by something called the apnea-hypopnea index. And that looks at the number of apneas and hypopneas that are happening every hour. So a normal situation would be less than 5 events per hour. Mild sleep apnea is from 5 to 15, moderate from 15 to 30, and then severe 30 and above. And that's how we grade sleep apnea at the moment. This has been an ongoing system which has probably spanned the best part of 2 or 3 decades. Why do we care? Why does it matter if someone has obstructive sleep apnea? So obstructive sleep apnea is linked to a whole host of different medical conditions that include an increased prevalence of hypertension, so high blood pressure, an irregular heart rhythm, heart failure and coronary artery disease, so people having increased risks of heart attacks, an increased risk of stroke, metabolic syndrome, which is part of this package where you get diabetes and you have fatty liver disease. There's an increased mortality in the severe obstructive sleep apnea group, and you also get, as a byproduct, increased road traffic accidents due to decreased alertness and increased sleepiness of the wheel because of increased fragmentation of sleep. And so actually, if I put this to you in a more network physiology map sort of way, we know that obstructive sleep apnea impacts several different organs, including the ones shown. And therefore, by just focusing on the sleep apnea itself or treating the sleep apnea itself, we're not really doing a service to the rest of the organ pathology that's involved. And actually, are we not really justifying who we're treating and why we're treating? And that's what I want to talk a little bit about going forward. Just before I do that, just a word on obesity hypoventilation syndrome, another common sleep disorder that we see. That's defined as a combination of obesity, defined by the body mass index above 30, some sort of sleep disordered breathing, and that could be any sort, whether there's sleep apnea associated with that or just low oxygen levels overnight, and daytime hypercapnia, so a raised carbon dioxide in the blood in the day of more than 6 kilopascals. Importantly, and perhaps idealistically, this is in the absence of other causes of hypercapnia. I think that's unrealistic in today's world, given that we're getting more and more obesity associated with a lot of other comorbid conditions. But that's sort of the original definition that was first sort of talked about. However, I want to look at it slightly differently, and this is where things are moving towards, where actually this is probably a continuum, where you've got someone with obstructive sleep apnea on one end of a spectrum, and you've got someone with full-blown obesity hypoventilation on the other end. But actually in the middle, you have different severities of other sleep disorders where you have sleep apnea, so obstructive sleep apnea, but low oxygen levels overnight, so what we'd call nocturnal hypoxia. And nocturnal hypoxia is really defined by having spent more than 30% of the night with saturations less than 90%. And then one step further is where you get obesity-associated sleep hypoventilation. So overnight, you're under-breathing, and your carbon dioxide levels probably elevated overnight, not that we measure this routinely, but in the daytime, you don't quite meet the threshold of saying you have obesity hyperventilation syndrome. And so I just want you to bear that in mind as we go through the rest of the talk, because I think talking about it as a continuum is helpful from a network physiology perspective. So what are the problems with the current pathway? The current pathway, really, the major problem is an over-reliance on a single metric, this apnea-hypopnea index, so the number of events that are happening every hour. It doesn't capture the duration of an event, so an event that's 15 seconds long is classified exactly the same as an event that's 30 seconds long. It doesn't capture the degree of hypoxia, and there are other metrics that perhaps do this, but they're not in routine clinical practice. It doesn't predict major cardiovascular outcomes, and at the end of the day, that's why we're treating a lot of these patients who are not really symptomatic from their sleep apnea, but we're treating them due to an added risk of heart disease in the future. It doesn't really predict the different OSA phenotypes. So there's different causes of obstructive sleep apnea, which is not really predicted very well by the AHI index. And therefore, we do a one-size-fits-all treatment approach, which actually may not be correct. And then in terms of obesity hyperventilation syndrome, there's a need for arterial blood gas measurements. There's quite a lot of pain for the patient to have these measurements done, and we may miss people earlier in their trajectory. So actually, should we be treating the patients who have nocturnal hyperventilation, i.e. those who are under breathing at night, but not quite meeting the threshold of obesity hyperventilation syndrome, and should we be treating them in a different manner? So I think this is where network physiology mapping and some of the tools that we've already discussed are very helpful. So very briefly, as I know that the majority of you will have attended a few of the talks previously, there are two concepts, sample entropy and transfer entropy. Sample entropy is simply a measure of complexity and simply looking at the degree of irregularity versus regularity. So for example, if you had a very regular pattern shown here in red, your sample entropy would be very low. If you had a completely random pattern shown in the middle in orange, you'd have a very high sample entropy, but that's not a structurally rich information signal. And if you had something that looked like this, where it was fairly structurally rich, you'd have a sample entropy in the middle of those two, but relatively high. And then from our sleep studies, we have different signals, and we know that from obstructive sleep apnea, different organs are involved. And so can we look at the transfer of information between nasal flow, heart rate, oxygen saturations, and respiratory rate and their various combinations? And can we find differences in different people that enlighten us to different phenotypic variants of these patients? And also, actually, is there any difference in different forms of sleep disordered breathing? So if someone has, obesity hypoventilation syndrome, do they have a difference in their entropy versus those who have simple sleep apnea? Just in terms of what prior work that's been done, you'll notice that a lot of this work's been done a significant time period ago, and this was a systematic review we just published recently. What has been shown is that approximate entropy has been used and spectral in the majority of studies, and they've found differences, so higher in obstructive sleep apnea versus normal. No one has looked at this previously in hypoventilation syndrome and the different stages of sleep disordered breathing. And so really, what did we set out to do? And this is just some pilot data from the initial work that we've done, is really we wanted to answer, can sample entropy and transfer entropy of commonly acquired signals that we obtained during sleep studies accurately distinguish different phenotypes of sleep disordered breathing? Can we develop and validate a new diagnostic pathway? As I mentioned earlier, 1 billion people worldwide have this condition, the majority of which are in low middle income countries, and therefore they can't afford the complex sleep studies that we currently provide. And so can we, with a simple overnight oxygen test, i.e. an oximeter, diagnose accurately sleep apnea in the same way that the apnea-hypopnea index does? And can we lead to a novel way of diagnostics, which is simpler and easier for the patient? And so we really looked at 4 signals. We looked at the nasal flow, the respiratory rate, which was derived from the actual nasal flow, because the abdominal thoracic belts that we had we found didn't actually give us good quality respiratory rate data. We looked at the heart rate and we looked at oxygen saturation. And these are the initial 6 groups that we looked at. And so we looked at 20 from each group. So we looked at the normal population. We looked at someone with pure obstructive sleep apnea. We then looked at those with severe sleep apnea. So that's defined as an apnea-hypopnea index of more than 30 with nocturnal hypoxia. So that's time spent below 90% of more than 30%. Those with severe sleep apnea and obesity hyperventilation syndrome defined by convention, i.e. a high carbon dioxide level in the day. Those with what I'd call pure obesity hyperventilation syndrome, i.e. those without severe obstructive sleep apnea, and those with, hypoventilation from other causes. Why did we do this? Internationally, currently, the guidance suggests that the treatment for people with this group, i.e. sleep apnea or severe sleep apnea with hypoventilation, have something called CPAP therapy, which is continuous positive airway pressure, a mask that they wear over their nose and their mouth, connected to a machine that delivers just one continuous pressure, or whether if you have a more hypoventilation phenotype, you get non-invasive ventilation. Again, a mask and a machine, but the machine delivers 2 different pressures. So quite different treatment strategies. If we look at the demographics of the population, as I said, there was about 20 in each group. So we had 120 patients in total that we did retrospective analysis on. They were aged roughly between 50 and 70 years across the board, equal male-female split, and no real differences in comorbidities apart from a slightly higher risk of type 2 diabetes. There was interestingly, no differences in any of the variability parameters when we looked at nasal flow, respiratory rate, and heart rate. That was interesting to us, and we can talk a little bit more about the transfer entropy side of things in a little while. However, I wanted to focus on what we found with oxygen saturation signals. So if we just look at the mean oxygen saturation, we can see that compared to the 6 groups from normal down to the sort of severe obstructive sleep apnea with hyperventilation, the oxygen saturations fell as expected because patients with the more severe end of the spectrum would be expected to be nocturnally hypoxic, have low oxygen levels overnight, and this sort of plateaued in the latter populations. If we then look at sample entropy of oxygen saturations, which was significant amongst groups, you can see that it peaks, and it seems to peak around about the patients with severe obstructive sleep apnea and hyperventilation, but then there's a sharp drop when it comes to those with pure hyperventilation, which I would add are a sicker group than those with severe obstructive sleep apnea. And that's interesting because that suggests that actually their oxygen saturation signal is less engaged, has a lower information transfer, and therefore perhaps less variability, meaning they're less able to deal with other things. They're therefore a sicker population at a higher risk of other pathology, which is in some cases sort of expected. This is just showing the same thing with the actual numbers. So you have an idea of what the sample entropy looks like. So it peaked around the 0.36 mark and then came down. What we also noted was in health, mean oxygen saturation is negatively correlated with the sample entropy of SATs, and that's been shown previously, and you saw some data about that last week, I believe. However, in our groups, we found there's no correlation between the sample entropy of SATs and the mean oxygen levels, which is interesting because actually what that suggests is that patients with sleep apnea who are nocturnally hypoxic, so for example, going from saturations of 94% down to 86%, only increase their sample entropy by a little bit. You would expect this number to be a lot higher given the negative correlation found in health, and that's not the case. And so that suggests that this population is not increasing their sample entropy as much as perhaps we would expect, meaning the system is less engaged than it ought to be, meaning that this populations are sicker than the normal population, which is of course expected, but useful to prove as it's not been done previously. Just as a sort of what does it look like in terms of correlation or association between the sample entropy of saturations and the original AHI, which is obviously the internationally known metric, we found it had good correlation with an R-squared value of 0.57, which was significant. And what we then went on to do is look at a 3D graph by plotting the time spent below 90%, because that's determining nocturnal hypoxia, the AHI, which is obviously the internationally recognized metric for diagnosing the severity of sleep apnea, and then our new metric, the sample entropy of saturation on the z-axis. And what we found is they fell into somewhat neat groups where you had the normal population down here, you had the sleep apnea population with just sleep apnea and no nocturnal hypoxia, and you can note that the majority of them are below 30%. This really big group, which really combined the severe obstructive sleep apnea with nocturnal hypoxia, and those with severe obstructive sleep apnea and hypoventilation, i.e. those who had confirmed daytime high CO2 levels, suggesting that actually these two groups were very similar in their phenotype, and that made clinical sense. However, that's not always seen to be the case. And then the last group was the pure hypoventilation groups, the sicker population, which sort of fell into their own category with sort of obesity hypoventilation syndrome, and the people with hypoventilation from other causes. Now, I haven't dwelled on that too much, but the other causes would include things like smoking-related lung disease and sort of chest wall disease and nerve problems, so motor neuron disease, for example. So from these 6 initial groups, you can see that we have one group which is normal, one group which is OSA alone, this group in the green box really behaving in a very similar fashion, and this group in the orangey sort of brown box behaving very similar fashion as well. And so we went on to combine these groups to look at 4 clinically relevant groups, and which we call normal, obstructive sleep apnea, and then what we classified as hypoventilation and severe obstructive sleep apnea. So this was anyone who had an apnea-hypopnea index above 30, a time below 90 of more than 30%, i.e. proven nocturnal hypoxia, but with or without a high carbon dioxide level. And then we looked at those who did not have severe sleep apnea, but still had nocturnal hypoxia, again, with or without a high carbon dioxide. So we were not using a blood gas to determine this. And the treatment pathways largely are outlined with the CPAP, as we talked about, and non-invasive ventilation. What did we find then? So if we just take the sample entropy of oxygen, again, we can find that it peaks at those with this sort of hyperventilation and severe sleep apnea and then drops off, very similar to what we found previously. And then we thought, can we determine, because we can distinguish OSA from the severe OSA and hyperventilation purely on the basis of the time spent below 90%. So actually, we broke it up into 2 groups and we looked at normal versus obstructive sleep apnea, and we found the area under the curve to be very good, so 0.95. And we broke up these 2 groups because clinically that's relevant, because the hyperventilation with severe obstructive sleep apnea we would treat with CPAP, whereas the hyperventilation alone we would treat with NIV, and that AUC was 0.90. We then went on to again create another 3D graph to see whether we could outline differences further, and this used the mean oxygen saturations, the time spent below 90%, and the sample entropy. And again, they fell fairly nicely into 4 distinct groups, as we've mentioned already. So we came up with this algorithm, and this was just obviously a predictive algorithm which has not been validated in a large population. But what we did was to find out, can we, by using simple overnight oxygen tests, using the time spent below 90%, split into less than 30% and more than 30%, in those less than 30%, if their sample entropy of oxygen sats were more than this value, which had 100% sensitivity in diagnosing obstructive sleep apnea, and we needed an extremely sensitive test so as not to miss patients with sleep apnea, then actually we could say they have obstructive sleep apnea and we could treat them as such. On the other hand, if they had time below 90 of more than 30%, that suggests they were nocturnally hypoxic. And so did they need CPAP or did they need NIV? And so we used this cutoff. And this, if you remember, the patients with severe obstructive sleep apnea and hyperventilation had a higher sample entropy than the other. And this therefore had a high specificity, was what we chose. So we chose a 92% specificity, because what we didn't want to miss is those with pure obesity hyperventilation syndrome, which would need the more aggressive form of management, which would be NIV. We then validated this in a different data set using 20 patients in each, 25 patients actually in each group. So again, another 100, and found that actually in the validation data set, they should probably say 25 versus 25, there was 100% sensitivity. And in the next data set, there was 85% specificity. So in small numbers, this held true. And future work really is to look and validate things at a much bigger population level to see whether this turns into anything going forward. Finally, just to look at the network physiology maps, where again, we took those two groups, normal versus obstructive sleep apnea, and we looked at the information transfer from these four signals, so sample entry, oxygen saturations, heart rate, nasal flow, and respiratory rate. And this is the normal group. The red outlined arrows are where there were significant differences between that. And what you can, for example, see is that in the sleep apnea group, there is a greater amount of information transfer from heart rate to oxygen saturation compared to the normal population. There is a greater amount of information transfer from the nasal flow to the oxygen saturation. But really interestingly, there is a reduced transfer of information from the oxygen saturation to the respiratory rate compared to normal, suggesting that there is an abnormality in the loop gain pathway. Loop gain is where your respiratory rate, which is driven by your ventilation, actually there's connected with your respiratory drive, which in main is connected by your oxygen saturations. And so actually there's less information transfer happening from the oxygen saturation to your respiratory rate. It means your body's not really responding very well to changes in oxygen saturation. And that's one aspect or one mechanism by which you may get obstructive sleep apnea. And so that was very interesting. If we look at the same thing for the hypoventilation groups, i.e. those with more time than 30% below 90%, you can see that actually there are also differences. So in the pure obesity hyperventilation group, there is more transfer of information from heart rate to oxygen saturations. Interestingly, in this situation, there's actually more information transfer from oxygen saturation to respiratory. So this is interesting because this is suggesting quite an engaged system. Which is different from the pure sample entropy that we looked at. And so a little bit of work needs to be done. And I know the transfer entropy is a little bit more complex, and it really does paint a picture when we look at the number of differences that exist between these two groups that we can detect purely by looking at these four signals. And I think that's very relevant to sort of going forward, because what's important to remember is that heart rate and oxygen saturation can be depicted purely based on, or can be obtained, I should say, purely from an overnight oxygen test, which is a very simple, cheap, reliable test to do. And so can inform future diagnostics and risk stratification, because what's well known is that decreased heart rate variability can lead to increased cardiovascular problems. And so is there a signal that we need to look at that also helps us risk stratify things going forward? So finally, just to conclude, we know that patients with sleep disordered breathing have increased sample entropy of oxygen saturations compared to normal, but it's not a simple linear group. We know that the sickest group, those with pure obesity hyperventilation, have a lower sample entropy of saturations, so a less engaged system. And you've also got loss of that normal negative correlation that we talked about, and perhaps the sample entropy is not rising enough compared to simply the mean when the mean saturation is dropped, again correlating to a less engaged system. We know that sample entropy of SATs has good correlation with traditional measures, with the AHI we talked about, and so can it be used to simplify diagnostics? And then finally, transfer entropy really provides useful insight in the small number of patients that we've looked at to see whether we can significantly differ amongst different groups, and can we therefore in the future identify different phenotypes and endotypes of sleep disordered breathing, resulting in a personalized treatment plan for each individual patient depending on their network map, so that we can risk stratify them and only treat those who are appropriate to be treated, therefore saving treatment for those in need. And actually that has global implications. So just as a summary slide, which we've talked about quite a lot, the sample entropy of SATs increased and dropped, and the transfer entropy from heart rate to oxygen saturation, interestingly, goes up in OSA, but actually drops in those with nocturnal hypoxia, and then goes back up quite significantly in those with pure hyperventilation. So a little bit more work to be done then. Finally, I'd just like to acknowledge and thank several people who've obviously been part of the process throughout, including my PhD supervisors, Dr. Mandal and Professor Hurst, and of course Dr. Mani, who's been an ever support throughout. But thank you very much.
Thank you very much, Amar. Amazing. That was excellent talk, and thank you for timekeeping as well. I'm very impressed with the 3D graph you showed, that how we can actually, of course, categorize different phenotypes by just looking at, of course, entropy measures as well as other physiological measures. Very, very impressive. And I'm very happy that your talk goes along very well with the sessions we had last week. We had a very nice session on extreme environment, and we discussed about hypoxia. Now we can see clinical application of those things that we discussed last week. Amazing. Thank you very much, really. We will have time for question and answer after the second talk. Of course, then we will have a panel discussion. And now I would like to introduce our second speaker, Emily Ito. I'm really delighted to introduce Emily Ito to the audience. Emily is a research assistant at the UCL Network Physiology Lab. She has a strong interest in interdisciplinary research, particularly at the intersection of network science and clinical physiology. Emily has contributed to development of novel methods for physiological network mapping in critically patients with sepsis. Emily has graduated from UCL from the Applied Medical Science program, and she was shortlisted for the Rob Clark Award by the Physiological Society for the best undergraduate research project. So we are very delighted to have Emily here. And Emily, please, of course, share your slides, and we are going to have a discussion and a very interesting talk about physiological network mapping in sepsis. Thank you, Emily.
Thank you very much for your introduction, Dr. Mani. So let me just go share my slides first. I think that's yeah, can you see the slides, hopefully?
Yes, very good. Excellent. Thank you.
Yeah, so today I would like to talk about physiological network mapping in sepsis. So in my presentation, it's mainly separated into two parts. So in the first part, I will talk about the current challenges in sepsis management, then discuss the importance of network physiology in sepsis research. And in the second part of the talk, I would like to mention some of our works that we have done employing physiological network mapping techniques in modeling sepsis outcomes. So why is sepsis management, what are the challenges currently in sepsis management? So first, I would like to talk about sepsis, and we all know that sepsis is a complex disease, and it happens due to systemic infection. So, and this systemic infection in sepsis can trigger complex physiological response across multiple biological scales. So as you can see in the diagram over here, at the molecular and cellular level, we see changes like mitochondrial dysfunction. At the individual system level, we see disruption in the immune system, metabolic system, and in the hemodynamic system. And all these can impact the whole body network and lead to multi-organ dysfunction and death in sepsis patients. So not only that, patients with sepsis are very heterogeneous, and they display different disease trajectory. So we know that in sepsis, some patients deteriorate early during the disease due to hyperinflammation and septic shock, while others manage to survive the acute phase of the disease, but later deteriorate and develop immunosuppression and die from secondary infections. So the main challenge in sepsis is that despite the complexity of the disease and patient heterogeneity, the management of sepsis is based on a very reductionistic approach. For instance, treatment of sepsis is based on a generalized protocol, which is mainly based on supportive care. However, we know that this approach is not really effective. In sepsis, what we know, however, is that early detection and treatment of the disease improves patient outcomes. However, current approach of evaluating sepsis is based on a simple model such as SOFA, and these approaches have a limited ability to detect early sepsis. So what is the importance of network physiology approach in sepsis, and how are network physiological approaches different from conventional traditional methods like SOFA? So first, conventional approaches like SOFA evaluate, which are linear models, they evaluate sepsis by looking at sum of organ dysfunction in individual organs. And although this way of evaluating sepsis is easy to understand and easy to use, it assumes it has an underlying assumption that sepsis is a simple disease and that patients with sepsis behave homogeneously. On the other hand, network physiology approach views the body as an interconnected system, and instead of looking at individual organs, it quantifies interactions across the physiological network. So I would like to just briefly talk about this amazing finding by Dr. Zada. And he did one of the earlier studies that employs network physiology approach to study organ connectivity in a population of critically ill patients. So what he did was that he evaluated organ connectivity in critically ill patients by extracting extracting physiological parameters from the blood test result that represent different physiological systems, and then he conducted correlation analysis to study how organ network connectivity changes is different between survivor population and non-survivor population. And what he found was that in patients who survived, he found a rich organ network connectivity, while in non-survivors, he identified a disrupted organ network engagement. So the reason why this finding is so important is because he found that insight into organ network connectivity using network physiology approach may provide valuable information about patient outcomes. But the only problem in Azada's correlation analysis approach was that it evaluates organ connectivity at the populational level. But in the clinical settings, it would be, since we deal with individual patients, it would be better, it would be nice if we could investigate organ network connectivity at the individual patient level. So how can we map physiological networks in individual patients? So there are currently two different approaches. One approach is called transfer entropy that Dr. Amar mentioned earlier, and transfer entropy evaluates physiological time series. Parenchylitic network mapping is another approach that evaluates organ connectivity using cross-sectional health data. And both these approaches have their own advantages and disadvantages. So advantages of using transfer entropy is that you are able to measure bidirectional interaction. So if you're analyzing two systems, for instance, the heart and the lung, you can observe how heart individually affects the lung and how the lung affects the heart. But the issue with dynamic network approaches like transfer entropy is that it requires noise-free data, which are not always available in resource-limited clinical settings. And the good thing about the parenchylitic network mapping is that it gives you a whole system-wide view. So the reason behind this is because there's more different physiological parameters that you can measure cross-sectionally compared to as a time series data. However, the downside of using parenchylitic network mapping is that because we are not analyzing changes over time, we are not able to capture causal relationship, and the organ connectivity we measure in parenchylitic network mapping is based on statistical correlation. So this slide just shows you the overview of the methodology of the two different techniques. For the transfer entropy, I'll just go briefly because Dr. Amar already explained it very beautifully. So what transfer entropy does essentially is that we take physiological time series, and then we measure information transfer between two physiological time series. And then when we map the transfer entropy network, we see that the nodes represent different physiological time series, and then the edges display the information transfer, where thicker edges would mean more information transfer, and the thinner edge would indicate less information transfer. So on the other hand, with paranclitic network mapping, we analyze cross-sectional data, such as plot test results, and then we select variables that represent the different physiological systems, and to view it as the body as a whole. And what we do at the beginning is that we conduct a similar analysis to what Dr. Azada did, and we first conduct population-level correlation analysis to identify significant physiological correlations in population of patients. And then for the significant physiological correlation identified, we compute paranclitic deviation. So how we do that is that we first identify, for the significant physiological correlations, we identify the trend in the reference population, which we usually compose it from patients with positive outcomes, like in 30-day survival, this would be survivor. And then once we obtain the trend in the reference population, we represent it as a regression line, and then we measure how individual patients deviate from this regression line. So if we look at the graph of paranclitic network, the nodes would represent different physiological parameters, and then the edges would represent paranclitic deviation across significantly correlated significant physiological correlations. And thinner edge would indicate that the patient is less deviated from the reference population across this axis, and more the thicker edge would indicate more deviation from the reference population. So to summarize the background, I've mentioned that sepsis is a complex disease that involves system-wide physiological dysregulation. We know that early detection and treatment of sepsis is important for improving patient outcome. However, traditional linear models have a limited ability to detect early sepsis. And from Azada's paper, we believe that we show that network physiology approach might be important in understanding how patients respond to diseases. Hence, we've looked at individual physiological network mapping, such as transfer entropy and paranclitic deviation, and then we think that it may offer valuable insight into patient outcomes. So moving on, I would like to talk about our research that we conduct in our lab and together with our collaborators. So what we were interested in was whether individual physiological network mapping techniques could be used to model sepsis outcomes. So our aim was to investigate use transfer entropy and paranclitic deviation, to investigate whether evaluation of organ network connectivity using transfer entropy and paranclitic deviation can predict 48-hour deterioration and 30-day survival in sepsis patients, independent of other measures of sepsis severity, such as SOFA and ventilation status. So since this was a large study, we've separated into two parts. So the first part on transfer entropy was conducted by Morandotti et al., and the paper is currently available as currently published in the Journal of Applied Physiology. The second part of the research was conducted by me and my collaborators, and the paper is currently available as a preprint. So this shows the overview of the research that we conducted, the materials and methods of our research. So what we did is that we studied patient sepsis population from the MIMIC3 database, So we studied 164 patients who met the criteria of who met the sepsis 3 criteria, and also who had the time-matched values for the time series data and the clinical data. So first, for the transfer entropy analysis, we extracted 30 minutes noise-free recording of the cardiorespiratory parameters, such as heart rate, respiratory rate, and oxygen saturation. And then for individual patients, we computed transfer entropy. So next, for the paranclitic, second part of the paper, paranclitic network mapping, we investigated this using the same sepsis population, so same 164 sepsis population. However, due to lack of time-matched laboratory data and time series data available for 2 patients, we had to exclude 2 patients, which gave us a remainder of 162 patients. So for these 162 patients, we extracted 15 different laboratory laboratory parameters that represents different physiological systems. And then first, we conducted population correlation analysis to identify significant physiological correlations in survivors for 30-day survival and 48-hour deterioration. And then we used these significant physiological correlations to compute then paranclitic networks for individual patients. And later, for the statistical analysis, we conducted multivariate Cox regression to look at the predictive ability of transfer entropy and paranclitic network mapping, independent of other measures of sepsis severity. And we also additionally conducted ROC curve analysis to investigate diagnostic performance of these 2 different techniques. So this is the results obtained from the work conducted by Morandotti et al. So we can see the transfer entropy networks for 30-day survival and 48-hour deterioration. So if you look at the network, so in Morandotti et al.'s work, she found that transfer entropy between survivors and non-survivors and between non-deteriorated and deteriorated patients were significantly different. As you might be able to see, patients with poor disease outcomes, such as non-survivors and deteriorated patients, have thinner edges, indicating less information transfer across the cardiorespiratory parameters, which suggests that patients with poor disease outcomes have uncoupling in the cardiorespiratory system. Furthermore, when we did multivariate Cox regression analysis, we showed that these edges highlighted in red were able to predict sepsis outcomes. So for the 30-day survival, we showed that transfer entropy from respiratory rate, heart rate, respiratory rate, and SpO2 to heart rate, as well as other measures of network indices, such as out degree of heart rate, respiratory and oxygen saturation, and in degree of heart rate, as well as some of transfer entropies, were able to predict 30-day mortality independent of these covariates listed at the bottom. Additionally, transfer entropy was able to predict 48-hour deterioration. So we see that information transfer from respiratory rate to heart rate, respiratory, as well as out degree of SpO2 was able to predict deterioration. So moving on to the second study investigating paranclitic network mapping. First, we conducted the population correlation analysis, and these are the results that we obtained. So as you can see, if you look at the correlation map between survivors and non-survivors and between non-deteriorated and deteriorated patients, you see that there is a distinct correlation profile between patients with positive and negative disease outcomes. which indicates that there is a different physiological response that happen in patients with positive and negative disease outcomes. But what is interesting is that if we look at patients with positive disease outcomes, for instance, between survivors and non-deteriorated patients, we see that their correlation profile is similar to each other, and the same thing happens for patients with poor disease outcomes. So non-survivors and deteriorated patients also exhibit similarity in their correlation pattern. So, for instance, in survivors and non-deteriorated patients, we observed correlation in INR and ALT and between arterial pH and bicarbonate. While in non-survivors and deteriorated patients, we saw a similar pattern of correlation in lactate bicarbonate and lactate pH. So overall, we identified 7 unique correlations, physiological correlations for 30-day survival, and 9 unique correlations for 48-hour duration. And these correlations were then used to compute paranclitic networks in individual patients. So this is the result we obtained for paranclitic network mapping in sepsis population. And as you can see, patients with positive disease outcomes, like survivors and non-deteriorated patients, have a thinner edge compared to non-survivors and deteriorated patients. And as you can see here, the edges highlighted in red were able to predict sepsis outcomes independent of covariates listed below, such as SOFA and mechanical ventilation. So from multivariate Cox regression analysis, what we found was that paranclitic deviation across the pH bicarbonate and lactate pH axis significantly predicted 30-day survival. But unfortunately, none of the paranclitic deviation values were able to predict 48-hour deterioration like in transfer entropy. So we will, since both transfer entropy and paranclitic network mapping were able to predict survival, we were interested in looking at the diagnostic performance between these two techniques and how they can classify survivors and non-survivors. And for this, we conducted ROC curve analysis. And what we found was that paranclitic network mapping, paranclitic deviation across pH bicarbonate and lactate pH with significantly predicted survival had generally had the highest sensitivity and specificity for predicting 30-day survival. So I've ranked the performance, so with 1 being the highest and 6 being the lowest. So generally, paranclitic deviations had better predictive performance compared to SOFA, while for transfer entropy, the results varied, with transfer entropy from heart rate and respiratory rate having higher specificity than SOFA, but others had lower, slightly lower sensitivity and specificity for classifying 30-day survival compared to SOFA, which is interesting. So to summarize the findings, and well, this slide summarizes the main findings obtained for both of the studies. What we showed is that network physiological techniques such as transfer entropy and paranclitic deviation were able to identify how patients with positive and negative disease outcome respond differently. So with transfer entropy, we identified that there is less information transfer in patients with poor disease outcomes across the cardiorespiratory parameters, indicating that there is uncoupling of cardiorespiratory system in patients with poor outcomes. Similarly, with the paranclitic deviation, we observed that patients with poor disease outcomes had higher pancreatic deviation, meaning that their physiological network was more deviated from the reference population. What was more interesting was that the physiological pancreatic deviation across physiological pancreatic deviation across significant correlation between bicarbonate lactate and pH lactate were significantly predictive of 30-day survival. And these axes are involved in acid-base balance. Hence, it is possible that in patients with poor disease outcomes, there is uncoupling of the acid-base, dysregulation in the acid-base compensatory mechanism. So secondly, we showed that network physiological approaches were able to predict sepsis outcomes independent of other markers of sepsis severity, such as SOFA and ventilation status. So both transfer entropy and pancreatic network mapping was able to predict 30-day survival. And transfer entropy additionally was able to predict 48-hour deterioration. So in general, we found that network physiological approaches show promising results in identifying early sepsis outcomes, as well as providing insight into different physiological response. And we believe there might be a potential clinical application of network physiology approach might be beneficial. For instance, pancreatic network mapping was able to identify dysregulated pathways, like the acid-base compensatory mechanism, and understanding dysregulated pathways in patients with sepsis and may be able to facilitate development of personalized treatments. And additionally, transfer entropy was able to predict early deterioration, which was not possible with the traditional linear approach like SOFA or even pancreatic deviation. So application of transfer entropy might benefit in making early decision-making, as well as for detecting and treating sepsis early to improve patient outcomes. So although we showed promising findings, there are some limitations we should consider. So the first limitation is the small sample size. So we studied only 164 patients and 162 for the pancreatic network mapping. And also the MIMIC3 database includes patients from a single hospital in Boston. So our study was included a single-centered cohort. So in the future, to validate our findings and to validate our findings, as well as increase the statistical power of our findings and reduce the selection bias, we should repeat the study in a larger multi-centered patient cohort. Yeah, so at the end, I wanted to thank the Physiological Society for inviting me here today and hosting this amazing webinar. And I would like to thank our organizers, Dr. Mani and Dr. Oyladin, and other collaborators involved in this work. And I would like all the audience for listening today. Thank you very much.
Thank you very much. Thank you so much, Emily. That is an amazing talk. Absolutely amazing. Thank you very much. For now, we don't have any questions. Thank you, Swapna says brilliant talks. Thank you very much. Thank you, Amar, as well. So far, there's no question. So I would like to ask if any of us in the chair has any questions, but the floor is open for question. If anyone has a question, please type it to the chat. We're happy to read it to the speakers today. So questions can be quite specific, so you can direct each question to any of the speaker, or you can ask general question. We all contribute as well to if you have anything to say in terms of answers as well. So Ali Reza, you raise your hand.
Okay, so I want to thank Emily. Thank you very much. Very, very interesting talk. Excellent. I love your presentation and the slides. So you need to teach me how you make beautiful slides like that. Amazing, really, really good. And so while we are waiting for the question answer, I have one question for Amar. And the question is, I understand very well that your approach is for diagnostics. Of course, you want to make sure that you have an accurate, easy diagnosis for sleep apnea and all of those other diseases associated with it. Of course, amazing. But based on your studies, do you think this kind of approach, network physiology approach, can give us maybe pathophysiological insight about these conditions? Because, of course, we have different diseases, we have overlap, but what are the pathophysiological insight that we can get from this kind of approach to this common disorder?
Yeah, so that's a great question. I think that we're realizing now more and more that sleep apnea has different endotypes and that, different mechanistic reasons why we get it. And for example, you can have pharyngeal instability, so you've got weak muscles of the pharynx causing it in the majority. However, some people have an abnormal loop gain pathway. And actually, for example, if someone has predominant loop gain pathway and we give these people CPAP therapy, we're not actually treating the cause of their sleep apnea. And so arguably you could give them something to impact loop gain pathway, such as a medication. So treatment for them would be different. And so a bit of work that we want to do is look at, because there's a group, I think, in the US who have endotyped patients with sleep apnea both invasively and have also tried to look at a non-invasive measure of doing that. But that's required a full sleep study. And so actually, can we use network mapping? And does network mapping, especially transfer of entropy between respiratory and oxygen saturations, does that give us an idea as to which endotype someone is? And therefore, does that tell us, what treatment they need, if any? And I think it's a good question to understand, because I think the people who have sleep apnea who are not sleepy, we're giving everyone CPAP because we think we should, but actually no major study and no systematic review really has conclusively proven that CPAP reduces cardiovascular mortality in the long term in the non-somnolent population. So actually, are we treating all these people when we don't need to? And I think we don't know the answer to that. And is it, do they have a different phenotype or endotype? And so I think there's a bit of work to do with regards to that.
Thank you very much. Amazing. Thank you. So you mentioned about loop gain pathway. So it's very, very physiological as well. So of course, we are talking about all of those integrated mechanisms that leads to, of course, regulation in the respiratory system. So I understand your approach is novel and hopefully will be used in clinical practice in future. But what is the approach to study this loop in clinical practice without using natural physiology? Is there any way that you assess your patient? How do you do that?
So we don't at the moment. There's no clinically accepted way of doing it outside the research setting. I think within the research setting, it's an invasive measure of carbon dioxide, oxygen, respiratory rate, tidal volume, that sort of invasively measures loop gain. But it's difficult to do from a clinical standpoint, and so there's no clinical way of doing that that's easily replicated, as it were.
Very interesting. Thank you very much. Every time I talk to you, I learn something new. Great. And Topa, can I ask other questions? Is it okay?
Yeah, no, absolutely. Do go ahead. I think towards the end, I have some few questions that we can rub mind on some of Emily's presentations as well. So yes, please go ahead with you.
So I have Emily, I have a question for you. Two questions for you. Many questions, but two of them for now. So the first question is about, okay, I think you mentioned that prognostically these methods can be used. You have used routine data, for instance, for parenchylitic network mapping, and also used beautiful data of transfer entropy and network mapping using time series. But so I can understand that they use for prognostication, they use for maybe detecting deterioration. But can I ask your opinion about personalized therapy, for instance? So is there any occasion that we can use this type of network mapping? Of course, we just talk about two types. Maybe there are other methods that will be developed or maybe other people are developing. What about its potential for personalized therapy? Can I ask your opinion about that?
I think there is a potential for at least using paranclitic network mapping for developing personalized therapies, because what we do in paranclitic network mapping is that we do the correlation analysis at the beginning at the population level, and then we identify, we study organ network connectivity in population with positive and negative disease outcomes, and then according to by looking at the correlation patterns in for instance survivors and non-survivors, we may be able to identify dysregulated pathways, and then maybe this insight may improve development of personalized therapies. And one paper by Dr. Oilade, he did an amazing work in, I think, patients with cirrhosis, and then he used paranclitic network mapping approach to see whether paranclitic network mapping can predict patient response to albumin therapy. And then he showed that indeed it can, paranclitic network mapping can predict response to albumin therapy. So I think applying similar approach in sepsis might be beneficial. For instance, we know that in patients with sepsis, they used to run trials on glucocorticoid therapies. And we know that patients, well, the clinical trials showed that in general, glucocorticoid therapies do not work. But then if you look at the papers, and they show, some of the papers show that actually patients, some of the patients respond differently. So some patients with sepsis respond well to glucocorticoid therapies, while some do not. But the reason why we do not use glucocorticoid therapies is because we look at overall in general it didn't work. However, if we look at the different groups of sepsis population, they were, I think, glucocorticoid therapies work for some well, it didn't work for others. So maybe potentially applying paranclitic network mapping, for instance, to test to subgroup, classify patients into different groups, and then test how they respond to glucocorticoid therapy might be able to sort of lead to personalized therapies in sepsis management potentially. And that would be great.
Thank you. Amazing. So I think we should find data or collaborate with other people who have this type of, that's amazing, this type of data to look at it. I think there are questions now in the topic. Shall I leave handle the question with you, please?
Yes, no, absolutely. So we've got two questions. They're directed to Emily, but of course anyone can chip in probably later. So Lujane is asking, amazing talks, Emily. It seems paranclitic deviation and transfer entropy are more applicable towards survivor prediction, but not personalized medicine, personalized management as of yet. So how can we advance this in clinical practice? That's the first question. I'll let you take that first question, and then we can go to the next question. So yes, Emily.
I think this is an amazing question. So again, I believe it is correct. So maybe using network mapping techniques for personalized management would be hard for now, but I think we can apply. It would be faster to probably take these network physiological approaches to predict survival or deterioration in clinical settings. I think how we can advance this is, first we have to validate our findings with a larger data set. So at least for paranclitic network mapping, for our research on paranclitic network mapping, it was more of a proof of concept study, because indeed our sample population was small and our study was single-centered. So I think in the future, if we validate with a larger multi-centered cohort, it would be important. But I think what's more important is our study was a retrospective study. So testing paranclitic network mapping and their ability to predict survival in a prospective study would be important, and maybe that will advance application of paranclitic network mapping, or maybe transfer entropy in clinical settings, hopefully.
Thank you very much, Emily. That's an amazing answer. If I may add to that as well, I think you've absolutely hit the nail on the head, essentially. One of the limitations is, like you said, this is retrospective data set. And it's hard to sort of tailor retrospective data set because it's already collected for an absolutely different aim. And then, of course, in future, maybe we could design studies that is able to look at probably maybe response to specific treatment, and that could then feed forward to future decision making in terms of being able to manage those specific subgroup of patients in a specific way, which sort of fit into the remit of personalized medicine, essentially. We have another question, which I would read to you. This is from Jacqueline, again for Emily. How were the biomarkers selected, as there are many biomarkers implicated in sepsis?
So we selected the biomarkers just to see, well, we couldn't select all the markers that are implicated in sepsis, but for instance, we tried to select a few of the biomarkers, which were one thing I think was available in the mimicry database. Not all biomarkers can be extracted, as we know in mimicry database, some patients will have some missingness in data. So we select those 15 physiological variables on the basis that these data were available in our data sets. And also they sort of, some of these will be implicated in sepsis. For instance, we look at bicarbonate, lactate, and pH level, which we know is important in acid-base balance, which previous studies have shown that is dysregulated in sepsis patients. So we did try to select variables that represent different physiological systems, although there might be some connections. For instance, urea, creatinine, they are sort of biomarkers for kidney function, but then creatinine is also implicated in liver function as well. So yeah, I hope that answered the question in general. So we selected the biomarkers based on data availability, as well as so that we get the general overview of different physiological systems involved in sepsis.
Thank you very much. I think that covers it, really. Ali, or does anyone have any question before I throw in some few questions that I've got?
No, do we have time for just a few questions? Basically, so thank you very much. The question is a very good question. I totally agree with Emily, but of course we always have hidden information, something that we don't know. There is a biomarker that we don't know and it's not discovered. So it is always good to bear in mind that we plot a network based on what is available or what we think it is relevant, but there must be hidden nodes somewhere that we are not measuring, and maybe they contribute to the network, and it is for future, and it's very, very important. So I have a question about availability of the codes for this type of analysis. Basically, so I'm based on division medicine. We are not part of the Department of Mathematics or Natural Sciences or Physics, etc. And so whenever we start collaboration with our colleagues, the question is, okay, where can I find the codes, etc. Can I ask Amar and Emily to see that if any of the codes that you have developed to analyze the data is available for other collaborators or other colleagues or other people who are attending or will listen to our webinars in future. Is there any of them available?
So I suppose the code, not specific to the sleep apnea side of things, but the sample entropy and transfer entropy code obviously are available from PhysioNet, and that's kind of what we used. So we're hoping to publish that pilot data at some point in the near future, and so we probably will make the code available once that's published on sort of a GitHub repository.
Thank you very much. Thank you.
Yeah,
Emily, what about you? Can I ask you the same question?
Oh, sorry. Wait a moment. Yes, so I did develop my own code for computing pancreatic network mapping. So what my code does is that it computes pancreatic network mapping using an approach I found using orthogonal linear regression, and the code that I developed for pancreatic network mapping is universal. So what it does is, as long as you have your own data set that you want to analyze, it can be unlimited numbers of patient data and different variables not included in our study. So as long as you have a data you want to analyze, and then you download the data I have uploaded on GitHub into your own file. The code that I've developed can compute paranclitic network, can conduct population correlation analysis and compute paranclitic network mapping, and also visualize paranclitic network mapping for your own data. So you just have to put your data in a specific format, but the rest of the computation can be conducted automatically by this code. So I just wanted to find the link and also probably put in a chat box. So I'll do that in a moment. So, but yeah, if you're interested in applying paranclitic network mapping, and I would be more than happy if you can contact Dr. Mani, Dr. Tope, or me, and I can help you go through the process of how to use paranclitic network mapping with your own data. I'll try to put a link to the GitHub in the chat box below. Yeah.
Thank you, Emily. Thank you. That's really, really excellent. Okay, so Tope, would you like to say a few words about to wrap up the session? But and also at the end, I want to show you one slide about our advertising, our last, of course, session, which will be tomorrow. And so, Tope, please.
Yeah, absolutely. I mean, the talk is so interesting. It would be impossible to physically actually wrap it up, but I'll try my best. I'm sorry in advance, Amar. I'm sorry, Emily, if I didn't cover all the very best part of your talk. So thanks again to Amar and Emily for great talks. Today we've heard about OSA, that's obstructive sleep apnea. And obesity, hypertension, hypoventilation syndrome. I have a typo here, and it's linked with increased risk of multi-organ dysfunction and failure, as well as mortality. The implication of the limitations of the current model used for diagnosis, i.e., the AHI, that's the apnea-hypopnea index, especially its reliance on laborious measurements and the fact that it does not cater to patients at the very far edge of sleep apnea, resulting in simplistic one-size-fits-all approach to treatment. He discussed the implication of network physiology approach to resolve some of these limitations, specifically used sample entropy to assess organ system engagement in subgroups of patients with sleep disordered breathing. Emily, on the other hand, introduced us to sepsis as a complex disease with highly heterogeneous subpopulations, and the limitations of the current models for prognosis, i.e. the SOFA score. We were shown the early works by Asada et al. On their sepsis patients using population-based correlation network mapping. Emily then introduced us to the alternative approach, which maps physiological network at the individual patient's level. She talked about the paranclitic network mapping and the use of transfer entropy as the basis of physiological network mapping. She beautifully explains the analytical details of how to compute those, as well as the strengths and weakness of the techniques. She described her work that she's done on sepsis patients using transfer entropy and paranclitic network analysis, as well as the findings and implications for clinical practice in future. I think that would, I think I've done my best there. I know I haven't covered everywhere, but thank you very much.
Thank you very much. Thank you. So I want to show you one slide, which is, of course, for tomorrow. So definitely tomorrow, so I haven't shared my slide, apologies. Okay, let me show you how to share. Okay, so apologies for, okay. So basically, so far, basically, you know, we had last week, we talked about, of course, network physiology. We invited Professor Ivanov, of course, excellent talk about, of course, the network physiology and all of the potential application, health and disease. We had a session about extreme environment, which I enjoyed very much. It was so many interesting discussions. And today we had an excellent talk. I'm very grateful to Amar and Emily for interesting discussion around application of network physiology in disease. So tomorrow will be the last series of webinars at the same time. So 3 p.m. BST, of course, British Summer Time, like today. We are going to talk about network physiology in liver failure. And so we have two speakers, Professor Sara Monteniese, a very good friend and collaborator and excellent clinician scientist, is going to talk about why liver failure is multisystemic and why we shouldn't only look at the liver, and it involves so many different organ systems, which is interesting. Of course, it goes along what Amar mentioned about how sleep apnea affects other organ systems. Very, very nice. And also, Tope is going to talk about application of network mapping in acute liver failure as well as chronic liver failure. And then we conclude the webinar series. So I want to invite you, all of you, of course, to attend tomorrow. And if there's any remaining question about all of the 4 sessions we had, tomorrow will be a good time to discuss it as well. So like today we had an excellent scientist, an excellent clinician scientist in this meeting. So that went very well. And also tomorrow we have a clinician and a scientist discussing things together. So hopefully it gives us a very good overview of application of network physiology. And so there are 2 very, very small things. First of all, I know that Amar is at hospital, so he's looking after so many patients. So thank you very much. While you are very busy in hospital, you are really, of course, you contribute to science, amazing. And I know that Emily, you are in Japan now, so it's midnight. And I know that it is very late for you, but you gave us such an excellent talk and so clear, so nice with beautiful pictures and very nice answer to questions. So I'm grateful to both of you. And of course, we have to all thank Abby, Simon, Sarah, and Kathleen from the Physiology Society. They organized the event so well. And so I'm grateful to all of you. So Tope, the floor is yours to final words. And then, of course, I hope that to see you all tomorrow.
No, absolutely. I think you've said it all, Ali Reza. It's an amazing talk that we've had today. We've had a good mix. We thank all the people, all the speakers. Thank you very much for making out the time and for giving a fantastic talk and giving us a peep through the window into your amazing work that you've been doing. And we thank all the attendants as well. Thank you very much all for showing up, for those that contribute and for those that don't as well. We hope you can contribute in future. We'll hope to see you tomorrow. Well, not a brilliant talk, but thanks to you, and thanks to the Physiological Society as well for all the work and the amazing artwork that they've done to put this together. Thank you very much.
Thank you, everyone.
Thank you.
Thank you, and have a nice day, the rest of the day. And Emily, have a nice rest of the night. Thank you.
Thank you.
Cheers.